I will be talking about genomic profiling to contextualize the results of the basic treatment that we've seen for smoldering multiple myeloma. So smoldering multiple myeloma is an asymptomatic state that precedes multiple myeloma, and it's actually fairly common. And so there's been increasing interest over the years in trying to understand who are the patients that are the highest risk that we should actually be offering treatment to as an intervention to see if we could prevent some of the complications that we see once multiple myeloma develops. And so we've seen across multiple trials in general that the responses and the deepness of those responses that we get are often a little bit higher than what we see in newly diagnosed multiple myeloma. And we wanted to understand if that's because we are intervening at an earlier state in clonal evolution, or if really we're just kind of treating a hodgepodge of patients that we're not really classifying the right way. Because we do know that there's tremendous heterogeneity in the risk scores that we use to try and decide who actually has high risk and who doesn't. And so to accomplish this, what we did was to combine two different parallel trials, one using KRD and one using ELO-RD, that look at treating high-risk smoldering multiple myeloma, and using whole genome sequencing and whole exome sequencing, we combine everybody together and try and understand what really makes a patient high risk. And what we saw, interestingly, across these trials is that, in general, the genomic complexity of these patients is much less than what we would see with newly diagnosed multiple myeloma. So these patients have less loss of tumor suppressor genes, they have less events on the MYC locus, they have less chromothripsis, for example, and they have less APOBEC mutational signature contribution. And so with all of that together, it's very clear that what we're doing on these clinical trials by conglomerating all of these clinical risk scores is somehow including some patients that have otherwise indolent disease. And that's not to say that these patients won't eventually progress, but certainly they do appear to be more indolent than what we would see with newly diagnosed multiple myeloma, and perhaps we're kind of over-treating some of these patients. On the other hand, in these trials as well, there are a couple of patients that do have resistance to therapy, and these are patients that do actually have a lot of these complex events. They are the ones that have chromothripsis, and they're the ones that have high APOBEC. And so what we see here is that despite the early interventions with KRD and ELO-RD, these patients are progressing. And so what we have here is this dichotomy where on these high-risk trials, we're actually over-treating some patients that may have indolent disease, getting them good outcomes for sure, but we can't really parse out who those indolent patients are with the clinical risk scores. And then on the other hand, we have these patients with truly high-risk genomics that are not really being served by the interventions being studied. And so with that in mind, it kind of puts all this into context where when we look at the results of these interventional trials, we really need genomics to understand who truly has high-risk disease. And then once we identify that, we have to figure out the correct interventions to offer to make sure that the patients really get personalized treatment and are treated appropriately so that we can prevent the complications that come with the transformation to multiple myeloma.